For it now. I think the awareness is there, so I'm not so sure, like when we started out, I heard every story that the surgeons who were not doing robotic will tell their patients. But I think now the awareness is there. Nobody wants large traumatic incisions, long recoveries. So I think if we keep the focus on how good it is for the patient, without compromising our ability to do these complex operations.
So 64-year-old gentleman comes for a mitral valve replacement. Do I have to do a CT angiogram on him to see his anatomy?
Yes, Sloan, if I could get you to answer that. Sloan? Yeah, the question is, can we get audio please from overseas? Yeah. Sloan, go ahead. Get the audio please from there.
We can't hear you.
I think. Oh. I don't.
Yes. No, we can.
Please keep their microphones on and volumes up. Huh?
Yeah.
So we don't need to go through every time.
Yeah. You
So,
can hear me now?
Yeah, go ahead, Sloan.
Okay. Okay, very good. So I love that question. The short answer is yes, I think you should. And I could give an hour-long lecture just on all the things that I've found with that CT scan. For instance, the size of the femoral arteries, the level of the bifurcation of the femoral arteries, particularly if you're doing percutaneous. I can't tell you how common a iliac dissection is after cardiac catheterization that is occult. So if you do put a cannula in that femoral artery and there's a dissection at that iliac, you might end up with an aortic dissection. Looking at the size of the ascending aorta, oftentimes we see other anomalies like an aberrant left subclavian artery, high diaphragm, etc., etc. So I spend a good 15 to 20 minutes looking at that CAT scan, and I think, at least in the United States, it's evolving into the standard of care to get a CAT scan just as if we were doing a TAVR. I think it's prevented far more problems than people realize.
Okay, thanks. Thank you.
Can I add something? Dr. Sam, this side, Dr. Lalit Malik. And thanks to you, it was a wonderful experience to share OT in Jaipur with you. And there are lots of, I learned lots of trick in mitral replacement from you, and that is working for me for very wonderful. And one thing you told me that CT for every patient is very important for robotic surgery, and whenever you have doubt, then go for CT angiography. Thank you so much, sir.
Thank you. Good to see you again.
Yeah, go ahead.
This is for Nitin. Nitin, hi, this is Bijoy here. Yeah, hope to see you in Mumbai, maybe in February. So my question is this. So the op-cap CABG is the commonest surgery done in India, without any doubt. Op-cap, beating heart CABG, whatever you call it. So how would you describe the progression from a complete beating heart surgeon to maybe what I would say is a dream, to be a completely robotic CABG surgeon, because that's where the future is. We have to embrace the robot. We don't have a choice. I mean, you can say whatever it is, but in couple of years' time, if you don't embrace the robot, we may be very difficult life for us. So how will you describe it? Like, do you have a fixed program? Like, let's say someone must have done 15 minimally invasive CABGs or 30, or like, can you have a formula for it?
Yeah, not a formula, but we should ask ourselves that how perfectly I can operate off pump CABGs with sternotomy without having a doubt in my heart when I start the case. So I feel if someone gets perfection in 100 cases, sternotomy off cam, that is very nice. If someone gets perfect in the sense that he can scrub in a case without having any doubt, to do off pump CABG in 50 cases, that's good for him. So it should be a self-realization, number one. But having said that, good number of off pump sternotomy CABG should be done before attempting MICS off pump CABGs. And to start with MICS CABGs, I published my paper in 2020, I guess, or 19. Experience of 100 cases. So in that also I realized that the first 20 cases of single and double grafts were difficult. It was never easy to do lima to LED graft when I started doing. So a good experience of thoracotomy CABG should be there, because finally you have to do a thoracotomy to do multi-graft or a single graft, because in first case you are not going to do TCAP. So you should have a good experience to do graft with a small incision thoracotomy. And I repeat here that whenever you feel that these three grafts I can do without having a doubt with the thoracotomy, then you are ready for robotic surgeries. It's not about conversion to thoracotomy for IMA harvestation. It's not about you can remove the cost of robot if you convert to sternotomy. It's not about the cost here. It's about sometimes you feel that okay, this attempt has been failed, I will do better in the next case with a robot. But the thing is that you have skipped one step. You have to be perfect in off-pump CABG sternotomy, then you should be perfect in off-pump MICS CABG, and then you should go for robot. Few surgeons think that they can transit from sternotomy to robot. That actually should not be done, in my view. Because finally, if you fail to do anything, thoracotomy will help you. And even if you do a thoracotomy, so suppose you are planning for TCAP, lima to LED, and you convert it to thoracotomy, patient will accept it. If you do sternotomy, then acceptance, you have to force acceptance on the patient. Because whole of the program you started to avoid sternotomy, then patient will accept, but you have to force it. So that should be the pathway. There is no fixed number. There are no fixed numbers.
So, just same question to
Maybe just a second, if I could add, I think to this particular thing, just looking back at our history, we trained like all other surgeons in the early stages, literally stopping the heart and doing whatever. So once in practice, somewhere in the mid-90s, the thoracotomy approaches or the mid-cap era had started. So we started to do those cases, and again they were very limited grafts actually, either mostly through anterior thoracotomy, which are very painful, cartilage dislocation, etc. So we basically moved the same incision to lateral side, whereby it became more of a bucket handle mechanism, so that way you're not really damaging things. And then, so we started the whole idea actually, because once we recognize sternotomy is a major morbidity in terms of the patient recovery to functional status. And yes, pump is needed in intracardiac cases, nothing we can do at this point in time, sort of implantation of valves without pump. So essentially, if we recognize that sternotomy, so how can we get away from it? And then we started actually back in the 90s, anterior thoracotomy for aortic valve, mini thoracotomy for the mitral, and then thoracotomy taking the IMAs down directly. Even bilateral IMA, it was not easy. Neck used to hurt and physical therapy every week at home. But we persisted and we did 800 or 1,000 cases actually through thoracotomy, multiple grafts, up to 6 grafts. Very small conversion rate actually to the pump, etc. And then of course so what it did was to be able to look at the vessels from the left side, to be able to reach those vessels actually, and of course in the early stages there will be displacement of the heart and anesthesia, screaming, CO2 going up and on and on. So I think when the robot came, it made it very easy. So I think Nitin is absolutely right. One must gradually progress. Now there are going to be people that they can go directly from sternotomy to robot, because see, in cardiac surgery we are not trained to do endoscopic surgery. It's always, then we start to do thoracotomies, etc. Is the thoracotomy necessary? I think if you can, I think it will be a great kind of transition. Also for future conversions, if one needs to, so you don't have to split the sternum. And so I think if you look at it now, going on to the robotic, as I mentioned, I think the protocol that we followed, which was mandated by FDA. So where people fail, I must have trained while in US 350 teams, mainly it's all on cardiac. And initially there was a 10% adoption. 3 months later it drops to 5%. Because the biggest issue was that people will come, Intuitive will bring them. We had a perfect setup, every day we are doing cases, so we can make it look easy. But the exercise that we went through, they did not follow. And they think that they can just do it, firstly wait for the ideal case. By the time ideal case comes, because cardiologists have access to LEDs, and 3 months later it's all gone from the head, what you saw. Then they will try, and if something happens wrong, the cardiologist will shut the program down. This was a recurrent theme, and I think this is the biggest challenge actually. So the only way I think people, when they are succeeding, is committing to it. Be patient, be persistent, and I think ultimately it's achievable. See, cardiac surgeons are highly skilled, not that others are not, but and we are dealing with high risk actually. We can kill a patient. So if you recognize that, we must put in our efforts. And sometimes people say, well, I have to relearn. So then I remind people how wonderful it is for the patients. And as you said, this will be the future. If 2 years later, if you are not doing, you will leave, patients will find surgeons that will do. So just imagine how much time we spend learning cardiac surgery. Why not spend 2 months, just like Harish did? Practice, 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 and then he could do it without much guidance. So I think if we must, the first thing is make a commitment. Be patient-centric. It helps us also feel good about ourselves when we see these patients walk out in day or two, and less complication, readmission, all of that thing. So I think follow a pathway. There's plenty of guidance available now, and as I think Harish pointed out, all kinds of things are available on digital media today. Watch them. I remember Sam Walke used to tell me, Sudhir, I watched your videos at least 20 times before I did this thing. And he was able to do it without going through formal. But then again, these guys are exceptional. So I think figure out your own level, but diligently commit to it. And don't dabble on it, I'll try type of thing. It won't work.
So